welcome and thanks very much for joining us again tonight. We have the session being run by Dr. James Brown, who's Principal Medical Educator, Education Advisor from the RACGP, and Paul Delena, Chair of the Lead Medical Educator Committee for the RTO network. My name's Glenn Wallace and tonight's session is on supervision of registrars undertaking teleconsultations. We'd like to acknowledge the traditional owners of the land on which this meeting is taking place in your respective parts of the country and pay our respects to their elders past and present and their families. Tonight's webinar was made possible due to the RACGP and RTOS, so we'd like absolutely to thank them for their contribution in making this possible, and also to Dr. James Brown and Paul Delena for making themselves available in their spare time, just as you have tonight in joining us. And GPSAs are supported by funding from the Australian Government under the Australian General Practice Training Program. Now, we did send the learning objectives for tonight's session out to you as part of the registration process, so I'm not going to run through those, but there they are up on the screen again for you. And I'm going to hand over to you, James.
Thanks, Glenn. So I'm James Brown. I'm on this teleconference in my new role as the Principal Medical Educator Advisor for the RACGP, where we've been working in a fairly manic fashion to try and develop an appropriate guidelines and approaches for RTOs and practices dealing with supervision and teaching during this COVID disruption. I'm also a supervisor myself, so I work in Trafalgar, which is a town of about 3,000 east of Melbourne, and we have a lot of learners in our practice. So some of this session I'll be sharing my reflections as supervisor, but mostly I'm here in my role as the Principal Medical Educator Advisor for the RACGP. Did you want to introduce yourself there, Paul?
Oh, thanks, James. My name is Dr. Paul Delena. I'm a general practitioner in Parkside in South Australia. I've been a GP supervisor for a number of years, and my major role now is the Director of Medical Education and Training for GPEX, which is the regional training organisation in South Australia, and I chair the Lead Medical Educator Committee for the RTO network. I'm chiefly here to represent the RTOs and to contribute to the webinar based on our perspective as well. So thank you for inviting me.
Thanks, Paul. So I guess I'm well aware of the difficulties that you as supervisors are dealing with. You're dealing with having to reorganise your practices. You're having to dealing with seeing patients in new ways. There's the financial implications of what we do. Fortunately, with the government's initiatives over the weekend, things are looking a little bit better on that front, I think. And you're also having to deal with being supervisors and enabling your registrars to teleconsult, and also supporting them in their own anxiety, which is compounded by their worries about how they're going to complete the requirements of their training. So certainly appreciate that this is a very challenging environment that supervisors are dealing with. So what we've been trying to do from an RACGP point of view is to develop some guidelines that RTOs can use to then support their practices in enabling their registrars to teleconsult. So essentially, as you see on this slide, the lines of approval run down from you as a practice, create a solution for your local problem. It needs to be within the guidelines that the RTOs, that your RTO provides, and their guidelines are within the guidelines that we provide. Now, in terms of how that's approved, that's going to depend from RTO to RTO, but fundamentally, we believe that practices and RTOs fundamentally know their job and their context, and that given appropriate guidelines, we expect that you'll be able to design solutions that will fit with those. And so we are not expecting pre-approval to pre-approve what RTOs choose, and I would presume, but I can't say that's necessarily the case, that the RTOs will do the same with practices. So you'll need to refer to your own RTO about how they will approve of whatever model that you have in a practice level. Did you want to talk about that, Paul?
Just to say that my understanding, James, is that within the existing vocational training standards, in practice telehealth by registrars comes under the existing standards and supervision. And we're talking about alternative supervision models for registrars outside of the practice setting, at home in quarantine or at home with practice closures, or outside of a setting in which the supervisor can observe the registrar directly. So that's what we're seeking. We trust the practices for in-training telehealth. We trust them for out of training, but we're required to get send some guidelines and get some evidence of how that's being set up in a different practice situation.
Can we have the next slide, Glenn? So as Paul pointed out, teleconsultations can fit within the guidelines of what's seen as safe supervision. And fundamentally, the intent of policies around safe supervision is supervision that ensures patient safety and supervision that ensures registrar safety. And so if you look at that from each of those points in turn, patient safety, we see that the same things that you would look at for patient safety with a registrar consulting face-to-face in your practice applies to registrars consulting through teleconsultations. So in essence, that is the capacity for the registrar to access the supervisor at the time of the consultation. Now, for more junior registrars, that's likely to need to be for the supervisor to actually join the consultation, which means you being able to dial in or video into the consultation that the registrar is doing. For more senior registrars, as we know, there is facility for them to be supervised at a distance anyway. So that equivalent on a remote supervision is calling on another phone and not necessarily joining into the consultation. So that's about the supervision. So that's about the supervisor being available and accessible for the registrar. And we'll look at a little bit later in some ideas about how you can actually join in the registrar's teleconsultation. The next thing is not that slide yet, sorry, Glenn, just back one. So the registrar clearly needs to be in a situation where they complete the normal tasks of a consultation. So that might be in the practice or it might be in their home. So they need to be able to have the means to access patient records. They need to have the means to print out prescriptions and get them to the chemist or to the patient, and also referrals and letters. And they also need to have the capacity to have the registrar, have the patient examined if necessary, because I'm finding probably a third, maybe even a half of my teleconsultations resulting in the need for a subsequent face-to-face consultation to examine them. Many consultations we can deal with by a history and whatever we can see on a video camera, but there are some where they need to be able to consult. Now, if the registrar can't consult, and we've got doctors out of our practice who are solely practicing off-site, we've had to provide the facility at the end of each session for their patients to come and see those of us who are still practicing on-site. And then you need to have some idea that the registrar knows what safe teleconsulting is and that they follow them. And that's particularly being able to recognise what you need to have in place to ensure that the patient is safety. And I guess to go back, that's about knowing when the consultation needs to be extended to a face-to-face physical contact. Did you want to add anything to that, Paul?
I think it's important to decide, and whether that's your receptionist or yourself, what consults are most appropriate for telephone, for video, or face-to-face. In our practice, I've I've been ringing up pre-booked people and making that decision myself. And then the receptionist have been doing that with patients who've rung through. But as James said, sometimes you do find yourself having to do something differently. I think you do have to judge which technology is best for the type of patient. And the registrar sometimes will need help with that as well.
But what we've been doing, but we'll probably be changing as we move to a new platform, is that many of the consultations have started off on the telephone and then have been converted to video with guidance by myself on the telephone, but that's just the way I've personally done it.
Mm-hmm.
So then if we look at safety of the registrar, which is our other responsibility as supervisors, and clearly they need to have a safe working environment. So if they're working from home, you need to have some idea that that's going to be a safe environment. And I might also say you need to be sure that the patient is going to receive the privacy that they need. It's not acceptable for the registrars to be doing their consultations in the living room with the rest of the family milling around. They need to have a means of debriefing, just as they do within the practice. So that's the capacity to talk about cases afterwards, and also to be able to debrief about things that they've found emotionally challenging themselves. And finally, the issue of registrar choice. This is not a usual way of consulting, and I think that if you're going to have registrars do this, it needs to be a negotiated arrangement, ensuring that they feel safe in the setup that they're being asked to engage with. Did either Paul or Glenn want to say about that? Because Glenn, you've had some feedback about that, haven't you? Glenn's not listening.
Glenn's
No, I'm just battling with my technology in an incredibly appropriate moment, as many registrars and supervisors will over the next little while be battling to get to know their technology and how to make that operate. Absolutely, I think one of the things that we're having feedback around is it's incredibly tricky as supervisors are learning at the same time as their registrars to use the technology. And in fact, that mimics Christine McHugh's comment in the questions box. I think dealing with a public health pandemic and how the practices they're working to adapt would be a real and valued training experience. We're all learning on the go. So I couldn't agree more, Christine.
Yeah, some really distressing patient situations we're coming across, aren't we? I had an elderly Italian man whose wife died suddenly, and he was so distressed, and he couldn't have anyone he could only have 5 at the funeral, and he can't get out and see his friends. It's some really poignant stories. Anyway, sorry, Paul, you were going to say?
I was just going to say on registrar safety, it's very important that it's very clear how you get access to the supervisor for the registrar, that you have a means of monitoring their consultations in some fashion, whether that be through the debriefing at the end of the day or random case or note review. I think you've got to treat it like any other consultations, that it still potentially can be a lot of errors and a teaching opportunity as well. So I think as much as possible, we try to consider it like you would any other normal consult in terms of teaching and monitoring and follow-up.
And I think that if they're remote to you as a supervisor, then it's prudent to make contact with them at the beginning and the end of the session so that they know that you're actually virtually there for them.
Mm-hmm.
We've got a couple of questions here. One is what platform are you using for video conferencing yourself there, James and Paul?
Well, I've been flying by the seat of my pants, but I've found if the patient has an iPhone and I have an iPhone, then FaceTime works okay. I have tried WhatsApp as well to cross the 2 platforms. The problem is that you can't engage in those without displaying your own number. And I'm looking at buying a separate phone and card to use or actually to use an old iPhone that I have and get another SIM card and plan, so that it's not my own number that's getting transmitted. But having said that, what our practice manager is looking into tonight with one of the doctors is a program called Health Direct, which apparently is free, and it works like a virtual waiting room. The patient clicks on a link on your website and end up in a virtual waiting room that then you can pick up as a doctor by going into the waiting room yourself. But I only know it as a concept. I haven't tried it, but it sounds pretty promising. I don't know if anyone else has tried it, have they?
We've got another one here. It's actually from Jared Connors, Chair of GPSA, and he's saying that in our practice it's not appropriate for the receptionist to assess whether a consultation should be a teleconference or face-to-face. What we've decided to do is when a patient rings, they'll have a teleconference with a doctor who determines whether or not the patient needs an examination. If an examination is deemed appropriate, they're booked in that afternoon with either the well examination clinic or the unwell clinic.
That's good advice, I think.
Yeah. Anna Windsor has asked, I have several registrars wishing to leave our area and move back to Sydney and do telehealth from their Sydney base several hours away. What do you reckon, James and Paul?
Well, I really think that that's up to the practice personally. Obviously, if they're going to be remote, they can't examine their patients. I would see that remote supervision really is for those situations where the registrar is in self-isolation or where the supervisor is. So I guess I wouldn't be all that sympathetic if one of my registrars decided to go back to Melbourne and just remotely consult. But I'm not saying it's off the plate as an option. What do you think, Paul?
No, I agree. I think we all have I personally feel like a responsibility to offer a complete care as I can. And if I'm not unwell and don't have a reason to be in quarantine, I think I should be following up my own patients for face-to-face if I can, or have an arrangement with a colleague. I think from an RTO perspective, that probably speaks of people who are wishing to be in a rural setting and trying to get back to the city, is not necessarily aligned with best patient care. It might end up putting a lot bigger load on the other rural practitioners in that town. So I'd have to look at that at a case-by-case basis to understand the reasoning behind it.
Hi, so this is the issue of what to do if your clinics run out of supervisors because they're all off in isolation or sick. So that the RACGP has recognised that the alternatives need to be available in those instances, and see that it's appropriate for anyone with a specialist GP qualification, which is generally a fellowship of RACGP or a FACRM, can provide the clinical supervision as long as they're available and approachable. And that means that they're committed to actually being meaningfully available for the registrar. So that's for clinical, the actual supervision of the registrar's consulting. For educational supervision, we see that should still remain within the domain of the accredited supervisor or an RTO educator. But there's no reason why that. So when I say educational supervision, I mean that's the debriefing that's separate to the consulting. It's the mentorship. It's the teaching sessions. It's making sure they're knowing what they're doing. All those sorts of things that supervisors also do, but are separate to actually supervising the registrar clinically. So that educational stuff that's not necessary immediately still remains within the domain of someone who has accredited educational skills.
We've got a good comment here actually, just as an aside, and Jackie says, it is appropriate for the receptionist to call the patient to go through the telehealth setup first to make sure that the technology is actually working and that they can actually operate it. So that was a useful contribution.
Yeah, I think that's a great idea because you can spend ages on the with a patient with them flapping around, pressing the wrong buttons and going to the wrong places. Yeah, to get them all boned up by the receptionist beforehand, I think is a great idea.
Can I just add, I think having a quick look at some of the chat in between, there's going to be enormous variation from practice to practice about how it's done, and I'm sure we can learn a lot from each other. The telephone screening, in my practice, when we started this, we were phoning every patient the night before to make sure it was appropriate. And there was a real art in keeping that to a minute per patient without turning it into the actual consult. And then that's moved on more to flowcharts to the practice, and ourselves doing probably 10 different ways of doing it, but every practice is learning as we go, and I'm sure we'll get better at it.
So this is a slide from a presentation that was given by GP Synergy. Is that right, Glenn?
That's right, or the contents of anyway.
Yeah, so just to acknowledge their input there. It's just important to know that the registrar knows how to use their phone. How do you make your number private? They all have their own settings within them for doing that. How do you put it on hold so that you can speak to someone while the patient isn't listening? And then, of course, how do you conference call? So the registrars are learning just as we are on how to use this technology for consulting. So I've just got a few slides of things that I've been doing over the last week. So with a smartphone, you can see that in a standard call, there's a plus to add a call. So you can add your supervisor in using that button. WhatsApp, which is a app that you can download to both iPhones and Androids. The difficulty with WhatsApp is that you have to have the person calling within your address book. So that means putting the patient in your address book, which is a bit of a challenge. And then, of course, they can see the number as well. And then the next one. So FaceTime, which is a iPhone app, I found that the most useful, actually. It's you just need to be aware that to get to the add person screen, you need to drag up the buttons that you first see. It's not immediately apparent. So
do you mean swipe up from the bottom of your phone?
Yeah, there was an arrow there, but it seems to have got lost. But so the bar that's you can see just above the mute button on the top screen, there's a little grey bar. If you swipe that up, you end up with the items down the bottom. And then Skype, quite a number of the doctors in our clinic are using Skype, and if you go to the three dots at the bottom right-hand corner, it then gives you the option to add someone into the call. And then the next screen. And then Zoom requires a bit of savviness on the part of the patient to be able to click the link and download the software and get it all going. So a lot of patients don't manage this, but Zoom has the capacity to invite someone in. I think I'm hoping as much as possible to go video rather than audio. You just get so much more information by seeing the patient. And I don't know how others have found it, but I've been able to examine throats and rashes and infected sores and things like that. And also, I get the patient, many of them got blood pressure machines at home. You can get them to take their blood pressure and their own temperature, things like that. Anyway, that's all I had to suggest then. As I say, Health Direct is looking pretty promising as a practice platform. Hopefully that'll just mean the patient clicking on a link on our webpage and being connected in.
We've got an interesting comment here from Philip. He says, we do not use mobile phones and teleconsults. We have an expensive office phone system with many digital lines and speakerphone, conference call and text facilities. We do not intend to use a mobile, and I'm surprised you're even discussing it. Well, Philip, I would suggest that not everybody will be in your practice. There will be some people that could be quarantined at various times that will not have access to the PABX system within the practice, and so that's why we're talking about these other technologies.
We haven't been using our PBX system because it's been swamped by patient calls in and out of the clinic. So we can't afford to have 6 doctors ringing through our internal system. That's why we've been using the phones.
No, I agree. We had exactly the same problem. I had to resort to using my own phone day one for that reason.
Yeah, and Carl has made comment that not every practice has got a PABX system either. So we've got a list of questions that people did ask. Beck Stewart has said live webinar is also a good option and not as swamped in terms of other technology as well. Now,
I see Alex there is using Health Direct, says it works well.
Now I'm going to ask you a couple of the questions that were posed by participants as they registered for the peer review. So one of them was, how do you suggest a supervisor juggles their own consulting by telehealth with being able to provide appropriate supervision to junior registrars also providing telehealth consultations? How are you managing that, James?
I manage it the same way that I manage my consulting supervision, so I don't overbook myself, and sometimes I have to put my patient on hold to address the registrar's need. What about you, Paul?
I'm at the current time, I don't have a registrar, so I'm not supervising right at this moment. And some of my answers are coloured by the fact that I'm spending the majority of my time running the GPEX and the RTO and just doing a couple of sessions, and it suits me with my patient clientele to do telephone because I know them all very well and they're long-standing patients of mine. I think if I had a wider patient profile, I'd be looking more at the video for that visual information, the diagnostic cues, and particularly what's underestimated, I think, the therapeutic presence of being by video as opposed to just by phone.
There's a good question here, James and Paul. You might have the answer to this, but it's from Fiona, who's asked, can you use your phone on no caller ID and use FaceTime or WhatsApp?
I don't think so, no. You have to have a separate card and number if you don't want them to have your number. And I don't think it's great for patients to have our mobile phone numbers.
Yeah, great. So in terms of the pitfalls then, what do we need to be aware of? How can we best help our registrars to do well with this? Obviously everybody's suggesting that they're learning at the same time. What are your key tips?
I think one of the things for me is to make sure that the other end of the call is private and confidential as well. We consult usually one-on-one, giving the patient confidentiality. And particularly for me, ringing up, I don't always know who's in the room at the other end of the phone. I have to also ensure that who I'm talking to is the person who I've rung. So I think it's very important to establish the ID of the patient and check the phone number and their address and who they are before you begin that, and just to check if there's anyone else in the room. And it does colour it. I had a consult the other day where the husband and wife were both present. They mentioned that to me, and that made it a lot easier for me to run the consult, knowing what I was dealing with at the other end. The other big problem we've had is people just not having their phone on them when we're trying to call them, not being ready for it. So even simple things like your receptionist giving them instructions to be available can make a big difference. So I think that privacy and confidentiality is really important to get off to a good start.
And I guess, I mean, it's interesting you should say about being prepared. Certainly for the registrar and for the supervisor, I can well imagine if you're trying to operate multiple technologies and you're not at work where things are systematized, set up, established and fixed, and you're using a computer that you may not have the charger cable for, that you may not have your phone charged, etc. Those are probably the things that supervisors would need to be having discussions with their registrars about.
I think that a really important issue is knowing when the patient needs to be physically examined. And I think, this is part of clinical reasoning, because it's a question one should always be asking at the end of every history is what other information needs to be collected. And if that information needs to be collected by a physical examination, then that's what needs to happen. So I think there's a risk of viewing consulting as being an event that happens without physical examination. In many cases, that's not safe. It's the patient does need to be examined, and many things are not apparent unless the patient is in front of you. So I think that giving registrars really clear guidelines about this, and also debriefing. You know, why did you decide that you didn't need to examine this patient? What was sufficient information?
There's a really fantastic suggestion here from Greg Gladman from Akron. Welcome, Greg. And he's just said that best practice SMS notification is handy just prior to phoning. The doctor will call you in the next 10 minutes. What a great way to help you prepare. Geez, I would like people to give me a heads up when I'm just about to be going into a meeting.
Mm-hmm. I think the other important thing for registrars, particularly those starting out, is making sure that they think about red flags in consults, and particularly how they might assess those both on history and by getting visual cues from the patient. And just that safety netting around the consults and the follow-up. It can be easy to forget those things if you think the consult's just an administrative matter or a certificate, but you have to think about the underlying condition and what you would do with your consulting room as opposed to what you might do on the phone.
And that brings up a really interesting area and another question that we've got from members, and that is how do you ensure that a GPT-1 registrar consultation is safe as distinct from your GPT-3 or 4? So what you set up with your GPT-1 and 2, 3 and 4 is very likely to be different. And we touched on it earlier about what patients are triaged and given to registrars. How is that being managed in your practice, Paul?
I would just caution people with junior registrars. I'd say that you want to have some previous on-site experience and be familiar with them in your practice, that you trust them in the routine consultation. Telephone and video is another step beyond, and I think it helps in selecting registrars with insider maturity to begin with. I don't think you're not necessarily forced into telehealth. You may be, but it comes as, it's still an optional thing for supervisor and registrar to agree on. I think we just have to make sure that you do trust that that registrar will be reasonable and you can give them parameters in which to work. Otherwise, it does get awkward, just as you would in day-to-day life in normal consulting.
No, I think that just as I think it's important when a GPT-1 starts, in fact, any registrar starts, that you spend time actually observing them consult, whether that be wave consulting or sitting in with them. And I think that when a GPT-1 starts teleconsulting, I think that you should be present to enough of their consultations to begin with to be satisfied that they're safe with them.
I agree.
Yeah, good point. I've got another question here. It's any comment, experience of providing registrar in practice teaching time or telephone? And I know there's lots of supervisors that are wondering how on earth they're going to be delivering their in practice teaching. So have you both thought about that from your own perspective within your own practices and how you'll be managing that with registrars? Or perhaps from your perspective, Paul, not having a registrar at the moment, what is being recommended by the RTOs in your capacity as LMEC chair? Yeah,
I think there are additional activities that work well in practice and through telehealth. For instance, random case analysis. You both will have access to the patient file and records. You can call up previous consults. You can discuss previous telehealth consults that have been conducted. You can still look at referral letters, investigation patterns, investigation results. And you can do, we've been doing a lot of our teaching through webinars and Zoom meetings, and I don't see any reason why you can't do your face-to-face teaching via telehealth as well.
You can also do teleconsultation observation as your teaching session.
Yep. Now, we've got another question here. It's about if we teach the basis of good general practices, history and examination, how are these young, inexperienced doctors going to phone-only consults?
Well, I don't think that we would want our registrars to be trained on only teleconsultations. I think that's fundamentally it. This is a part of consulting, particularly at the moment, but I suspect it'll become increasingly part of general practice in the future. So it's a skill to have, but it's not the full breadth of general practice, and it's not sufficient if that's the only experience that they have.
Yeah, sure.
I agree. Yeah.
Sorry, Paul, go.
I was just going to say, I do quite a lot of work by phone already, whether it be results or checking up on patients, and particularly being, you know, a bit more part-time in my practice now, I do have to do a lot of out-of-hours work following up my patients, following results and getting in touch with them. So I think it's been a part of practice. For the moment, it's going to increase quite a lot, and then it'll go, I don't think it'll go back to where it was. We'll have telehealth as a bigger aspect, but I think this is going to be the new normal, and telehealth will continue on in different ways. And there are some advantages in that we might actually be recognised for it in the future.
I noticed someone here said how exhausting their registrars found doing teleconsultation after teleconsultation. I'd have to agree with that. I was absolutely knackered this morning after doing a morning of teleconsultations.
I think that's an important point about monitoring the registrars as well. It's new to everyone. And if it's hard for us after decades of experience, it's going to be very hard on them. And we have to really, as any good supervisor does, keep a very good close eye on them and support them through this difficult work and difficult time, personally and professionally.
It's a really good question here, and I hadn't actually considered this, but obviously in the day-to-day of a practice and supervision of a registrar, you've got the in-practice teaching, but you've also got the corridor consults. You've got the registrar popping in and out, incidental conversations around the tea room, etc. So Kylie's asked, how are supervisors managing the teaching requirements for registrars during this time? We normally do a mixture of observation teaching and tutorials. We're still carrying out tutorials, but put a pause on our observation teaching. What do you say about that, Paul and James?
Well, one thing that came out of our practice, which was interesting, was I work in more of a setting where the doctors are independent contractors, and they felt that the practice wasn't necessarily responding as they wanted to, and set up their own WhatsApp group and drove a lot of changes at the practice in telehealth and flu clinics and everything just by getting together in that environment rather than calling a meeting every week. So it's just another thing to monitor, but it made me wonder about the benefit of that as a supervisor with your learners and having that direct contact through instant messaging and other networks like that to assist in that corridor type teaching.
And James, have you had a registrar sit in on you conducting a teleconsult to observe how you actually conduct it?
No, I haven't, but it's a good idea.
Yeah,
I think it's pretty important, really. It's
perhaps a foundational activity to do with your registrar before everybody launches off into their own homes.
I think you're exactly right. Yeah, I think it should be considered essential. I'm embarrassed to admit that I haven't done it.
One of the things that we've been coming across with concerns that supervisors have been sharing with us is the need to document exactly what's happening out there on the ground in terms of supervision for registrars that are not going to be in the same locales as their registrars. But also ensuring that the registrars understand how the consultations are going to work and documenting those sorts of things. We've been suggesting that perhaps that onus doesn't necessarily all need to reside with the practices themselves, and actually a fantastic way to get that documented is to have the registrar complete that documentation and then check it with their registrar. And in doing that, the opportunity obviously then represents they either understand it or they don't. And it's going to flag very quickly for the supervisor whether or not they've understood the conversation around how telehealth will work within the practice, within the context of remote supervision and how that remote supervision would take place. How do you think that would work with your registrars, James?
And I think it's a good idea, giving people a structure to judge whether or not they're fulfilling the requirements of a particular activity. So I think that we all sort of take a double take when we're asked, or we ask our registrars to do more documentation. But I think that the document, at least initially, that gives guidance on what's expected, and then the registrar can check that against their initial consultations and share that with their supervisor. That sounds very reasonable. It's perhaps a resource that we should be producing for supervisors and registrars to use as a check, this structure for critiquing their own performance, to share them with their supervisors.
Can I just add that I think the more that you get opportunity to watch your registrar and then watch you in an in-practice setting before you embark on out-of-practice telehealth, if possible, that is ideal. I think personally, I found it a lot easier to go into the office and do my telehealth and have the support of the staff and the paperwork and get everything organised. Getting it all sorted there first and practicing it there before taking it home, I think it's going to be a lot easier on everyone, if that's possible. Obviously, quarantining and closure of practices and so forth may not allow that, but where possible, I think have that practice in the practice first and see that as the default, and out of practice if you have to.
We've got Sarah. She's saying, Sarah Gunny from GP Synergy. Welcome. Synergy, we have a supervision plan completed by the registrar. It was excellent and very useful. There you go. So they've proven the concept. The registrar completes it and has it signed off by their supervisor.
Be good to be sharing those resources, wouldn't it?
Absolutely, and I have to hats off to Akram for sharing all of their teleconference, telehealth information open source. And I've also seen JCU provide all of their content open source. One of the biggest challenges is there's so much amazing content that is developed that is locked behind RTO education platforms. So more and more we're seeing people move to an open source format, and I think that's the best thing and direction for this particular industry, such that there are no barriers to the information that we need, particularly at this time. Sheila has said, I'm doing my training with my Term 1 registrar tomorrow and intend to try a teleconsultation then. Good on you, Sheila. Fantastic. And that's a good one from Adrienne, who's suggested that obviously you miss your corridor teaching room consults, but maybe booking this into your appointment book. So actually being structured because you have to be, and making sure that you put in structured time slots to be able to quickly check in with your registrar and for them to check in with you. I know certainly from listening to many supervisors over the years, talking to their registrars, that they're most concerned when they don't hear from their registrar. And certainly one of the things that was identified in the GP Synergy webinar the other day is that registrars may in fact ask or less questions, may be disinclined to ask supervisors at this stage. So if that's the case, then you need to cater for that and make sure that you reach in and make sure that you set the expectations of touching base around patients and in between patients. We've got one here from Charles, and that's the older patients prefer telephone consults as they're not tech knowledgeable, especially in remote areas. So I think that's a good example of the need for registrars and supervisors, all clinicians, to be adaptable to multiple technologies. I'd imagine that you're employing both, James. Is it particularly one or the other? Do you find, is it only oldies that struggle with the technology?
Particularly the oldies, but some people my age, they're not very old, have been struggling with it.
Indeed.
But I think that, I think that the sad thing too is it's the elderly that are becoming most isolated because they're being told to stay entirely on their own. And I think that there's going to be a lot of mental health strain on particularly that age group. I'm just staying here with my mother at the moment at 86, with her church and all the other things closed down. And I think that if we can enable them to use video technology, it gives them a better experience of contact.
Yeah, that's great. We've got another one here from Colleen Bradford from WAGPET, actually, and she said that they've been doing at WAGPET clinical teaching visits via video stream, and it's been working quite well. So it's fantastic to see that they've actually been able to go ahead.
No, we've been doing the same with Skype and Zoom and other formats to observe registrars as well.
Yeah, we've got a fantastic comment here from Peter Stevens as well. And it kind of goes to one side, but absolutely to the experience of working within a practice, and that is they're using Discord for daily meetings to have remote access to the software, including registrars' active files. Now, I guess one of the things that brings up for me is the daily life of operating within a practice. There will be practice meetings and those sorts of other administrative things that you go through. And we've talked earlier about the intensity of working patient after patient after patient on telehealth platform, and I guess the importance of scheduling in those regular and incidental conversations that would occur normally within a workplace would be fairly important as well. You won't have necessarily the opportunity to be having the random conversation that you would normally have. Apologies for the cough. I promise it's not COVID-19. I have asthma.
One of the things we did in our workplace at the RTO was institute Friday night virtual drinks, and that was one of the most socially interesting things I've been through. But the effect that had, particularly on staff who were a bit detached from each other, because in our office there's no one in our office of 60 people. They're all at home. And having that kind of social catch-up was really important, and I think that would apply to practices as well. Absolutely.
When you start to think about the non-clinical component to GP supervision, the mentoring, the pastoral care that goes on both inside and outside of practice hours, those things are going to be missed by registrars in this context. So thinking up and creating opportunities to connect will be really important, I think. James, has any thought been given to that in your practice?
No, socially we've developed a few groups, but at the moment a lot of us are still on site, so it's not an issue. But well, I guess it's an issue for the two that have chosen to be off site. But yeah, I think that's a good thing for us to look into. I noticed there's a question here also about the problem of recording Zoom. I think, just to mention, it's important that you don't record the patient consultation, because if you do it, in many states that becomes a legal part of the medical record and has to be kept.
Yeah, sure. Purely logistical thing now, Iman has asked about the reimbursement of telephone, internet and electricity for use from working from home. If I can venture into this one, certainly electricity, telephone and internet, most people would have within the normal functioning of their home, and that would be come a tax write-off for them. Where they don't have an internet connection at their home, that's going to be something that practices are going to have to navigate, potentially where there's no other option but for them to operate from a home environment, and that will become a business decision at the end of the day. So there's no hard and fast on that particular one, but if you've got an employee that needs to work from home, that's something that you are absolutely going to have to work through. Can I work as a locum with different telehealth platforms? Do I need individual provider numbers or locum shifts?
My understanding is the provider number is linked to the primary place of employment, but I'm not sure about multiple locum sites.
We've got a question here about e-prescriptions are available in Australia, just hasn't had a lot of uptake. Our practice is trying to set this up. I hazard a guess, by the time we're at the other end of this thing, practices are going to be so well set up for telehealth, it's not funny. But has setting up e-prescriptions been challenging? And have you had to do anything in terms of training with your registrars to set them up for this next phase, James?
I don't think I can claim any expertise or experience there. I'm afraid that hasn't been a big part of my view. I'm sorry.
Well, I don't think they're actually, I haven't seen them actually available in my area, and I just noticed from the chat that someone's written here that it might be a few weeks away. Maybe there's some areas where they're trialling it earlier than others, but it's not something we're routinely using. I was interested to hear at the Department of Health webinar this week that they were accepting digital signatures and clear photographs of prescriptions with a signature on them to be emailed to pharmacies. Eventually the hard copy has to get there as well. The exception was S8 drugs, but for routine drugs they were accepting quality photographs, which I hadn't thought about doing, but that's another option compared to trying to fax from home or so forth.
Yeah, good. Christine McHugh is saying she's feeling more confident about supervising telehealth, so that's a fantastic outcome from tonight.
Most of the RTOs, I think, apart from their policies and procedures, are providing links to the colleges and their resources, and there are quite a lot of other resources out there around telehealth. A particularly good one going around from the BMJ on using telehealth in COVID cases, and talking about red flags and safety netting, and a nice decision support tree on how to manage that, which I think registrars would find very helpful as well. So I'm happy to send those to Glenn, the ones I've got, and certainly between RTOs we're trying to share a lot of those resources because we're trying not to reinvent the wheel.
That's fantastic, and I think that draws out another point at the moment, and that is there's more than enough information out there. Probably one of the biggest challenges right now is the curation of that information, and because there's so much to go through. So Paul, I would happily accept that, and we'll make sure that those the best resources, the cream of the crop from the perspective of the RTOs of what supervisors can use to guide their discussions would be really useful for supervisors, I think, as well. Ash has said, reinforcing the critical question of when physical examination is needed and how are we deciding this will be important for all supervisors, I'm assuming.
Yeah, thank you for all the feedback. That's been helpful.
Addressing emotional well-being of our registrar. Like many GPs, they are stressed. Absolutely, could not agree more. And we hear, certainly I'm being approached for commentary about the stresses that not being able to sit their exams is going to place on registrars, and what that means in terms of them being able to stop being a registrar and be paid as a consultant. There's all sorts of stressors that are present in the current day for registrars. And those same stressors from a different perspective exist for the practice managers, the reception staff, the other administrative staff within the practice, and the supervisors themselves. So I have to say, from GPSA to you, from the RTOs, colleges and the likes, we know how hard you're working and how complex this is, and we're here standing right beside you. Please let us know if there's something in particular that we can support you with. We absolutely want to for you. Now,
there's a good comment here. Reassure registrars this is not normal general practice.
I'm sure it'll start to feel normal after about 6 months.
I think that's an important point, Glenn. I think on the concentration on telehealth, we forget that for most of us, it's a blended job. And the more that we can ensure people have some in-practice time as well as telehealth time, the more rounded their training will be, and they'll probably be more supported from the staff within the practice, subject to safety and whatever practice arrangements you have. But I think that would be the ideal, a bit of both, really.
Yeah, absolutely. Okay, so in terms of what's up next, obviously I'd like to thank you, Paul. Thank you, James, very much for giving up your night, well, an hour of it anyway, and in preparation of this webinar as well. Later on this week, we're going to be conducting another webinar, which is how to conduct a telehealth consult for registrars and their supervisors, for those that are still scratching their heads wondering what they're going to be doing in subsequent weeks. That's on Thursday. In fact, it's Thursday the 2nd. Sorry, I got a bit distracted today while doing that slide. And that's at 8 until 9 p.m. So it's Thursday the 2nd of April, not March. We would also like to acknowledge the Australian Government and the funding that GPSA receives under the Australian General Practice Training Program. Thanks so much to RTOS for making this possible, and also obviously RACGP. Thanks, Paul and James.